Hello everybody, welcome back to our masterclass series on the challenges of IHC staining. I am Bettina Winkler from Visiopharm. Today, Paul van Diest from the University Medical Center Utrecht in the Netherlands will present the results of an extensive IHC stain and stainer evaluation performed using Qualitopix. Paul is a board-certified pathologist and is head of the pathology department in Utrecht since 2003. He will answer your questions after the talk, so please add any questions to the chat. Paul, please go ahead with the webinar.
Good afternoon. Thank you all for being here in this webinar. And what I'd like to do today is share some experiences that we have had over the last couple of years with monitoring immunohistochemical stain quality with artificial intelligence. First, a few disclosure. I'm a member of the advisory board of a few companies. And we have some collaborations with different companies, but all the money goes to the department. So I have no personal benefit from any of these activities. So basically what this is all about is that more and more systemic therapeutic strategies become available, like hormonal therapy, chemotherapy, antibody therapy, small molecules, and also immunotherapy. And to make sure that the right people get the right treatment, the right very expensive treatment, we're using biomarkers to select or sometimes deselect patients for this type of therapy. Now, if we do that, we get an optimal balance between effectiveness of the therapy on the one hand and cost and side effects on the other. So this plays a very important role in the daily practice of pathology. There's molecular biomarkers that we use, like a lot of different gene mutations, just to name a few. Estrogen receptor, HER2, PIK3CA, c-KIT, EGFR, and many more genes, but also tumor mutational burden and microsatellite instability that play a role in selecting patients for immunotherapy. And BRCA and homologous recombinant deficiency, also for some types of chemotherapy and PARP inhibition. And then there's a lot of immunohistochemical biomarkers that we use a lot in daily pathology practice. There's a long list. I'm not going to mention all of them, but I'm quite sure that some of these will be very widely in use, like the breast cancer antibodies, HER2, ER, AR, and the microsatellite instability markers. So these antigens can be detected with immunohistochemistry, and we do this a lot. And sometimes in practice, there are a few problems with that. This means that not all the stain quality is always optimal across laboratories, and we have some reproducibility problems in assessing the amount of staining that we get in our immunohistochemistry. Just a few examples to make that point. For HER2, this is our own results from comparing different laboratories in the Netherlands. And you can see that there are some labs with only 5%, 3+ HER2 cases, and then there are labs with 12 to 13% positive cases. And this is a difference which is, of course, not acceptable. For ER, you also see quite some differences, like one lab that didn't do a lot of staining, as you can see here, that had only 77% ER positive cases, and there were a few labs that went over 90%. So this points to systematic differences between labs when it comes to staining of these two antigens, and that, of course, is not acceptable. This is another example where you can see some variations from different runs within the framework of quality control. This is the Nordic, where you see that insufficient staining quality was present in the runs for 32% of the labs. And this is PDL1, where you also see that there is quite some variations in the EQA run. And another example, you see here the pass rate within these external quality control rounds. And you can see that that varies a lot. In the beginning, in 2017, it was way below standard, with only 150 labs passing the quality control threshold. And you see over time that it still varies a bit. It goes up quite nicely, but in the last year, there was again a drop. So this points to the fact that immunohistochemical staining is not just a reproducible and stable technique in clinical practice, but there can be problems that need to be detected and solved. Now, one of the big advantages of AI could be that this can help to solve these type of problems. I'm quite sure that you've seen many examples of this. The Go player that is pretty desperate after losing to the AI. The Google self-driving car, in which AI plays a very important role. ChatGPT, I'm sure everybody has tried this. This is amazing what this produces. And also this program Midjourney, where you can produce amazing pictures by just putting in some text. So what about pathology? This is just, breast pathology. For all the other tumors, there are, similar or perhaps even different types of applications. But you see the many areas of application that AI could find just for breast cancer. I'm not going to mention them all, but you see that one of them also for breast is stain quality control. So let's focus on that a bit more. So I think that we all know that the quality of immunohistochemical stains may vary, and that for the mentioned biomarkers and therapeutic targets, this can provide big problems. This is just a visual example, right? This is PD-L1. On the left and right, you see the same cell line, stained with the same stainer, with the same antibody in the same lab. And it's quite visible that there are, big variations in the PD-L1 intensity, and that's again not acceptable. And this is not unique. All of us experience some stains that have to be redone because we can visually detect that there is a problem. Now, that's probably not sensitive enough, so let's look a bit more into detail and dig a little bit deeper. We've been experimenting with the Qualitopix approach by Visiopharm. This is based on cell lines with a standardized range of expression of a certain protein. What you see on the top right here is an example for HER2, where there are 4 cell lines that have been constructed into a tissue array that you mount on a slide, as you do with normal control tissue that is derived from your own lab. And one core is 0, one is 1 plus, 2 plus, and 3 plus. You mount and stain these control cells with the tissue of interest. Then you do the staining and you measure the quality of stain over time and you depict the results graphically. Now, let me give you one result, what happened when we run this for a while with the HER2 staining that we did. So what you see here is a graph where, the different days where we did these measurements are depicted, and you see that this is the 0, 4 for HER2, and you see there is some spikes. Some spikes were even, the 0 goes up to the 1 plus range. You see the same problem is present for 1 plus. It's most of the time quite stable, but in the beginning here, we had some spikes up to the 2 plus region. And that can prompt reflex testing with in situ hybridization, for instance. The 3 plus was most of the time quite stable, but you see the 2 plus was basically quite unstable all the time. And we ran this through the Nordic quality control assessment, and we scored poor, as you can see. So what we then did is we replaced the antibody. After that, you see that the results were much more stable, almost flat lines for the 3 plus, 2 plus, 1 plus, and 0 plus. We did the Nordic control again, and we scored optimal. So I think this shows that you can detect the problem, you replace the antibody, and then you fix the problem. So we decided to dig a little bit deeper and try some more experiments because we were not really happy with what we found, and we wanted to find out if perhaps in the stains there were also some problems. So we did a single center study in our own lab here in Utrecht, and we used 5 different benchmark ultra stainers from Ventana. And we did most of the experiments on HER2 and some on PD-L1. First of all, we again quality checked the material that we had, the tissue array block with the 4 cores by FISH. It has been validated by FISH for the company, but we decided to do it again. And you see a very nice range of spots in the 0, the 1 plus, the 2 plus, and the 3 plus cores. So this block was good, and we decided to use it further. In the experiments, we cut 3 micron thick ribbons, and we made sure that from each experiment, the sections that we cut from the ribbons were very close together to reduce that type of variation as much as possible. We did all the tests with the Ventana stainers. That was calibrated before by the company first, before we put them into practice. And also we do regular quality control within the framework of our own quality system. So basically, these are machines that we use every day, and that should be good. Also, in the different Nordic quality control runs, we scored optimal ratings for different antibodies. So we had no indication that perhaps there was a problem with these machines. The slides were scanned with a Hamamatsu scanner to reduce variation within the lab. So first of all, we decided to do manual stainings to make sure that it's not us, right? That it's perhaps something in the lab, that it's the water or, the people that are doing stuff. So we did manual experiments for HER2 without the machines, and you see that the variation between the different cores is minimal. So I think that excludes that we have any inherent problem in the lab with this type of antibody. And then we did some stain variation experiments. So we repeated the HER2 experiments, and for all the 5 machines that we have in use, we used the same slot in all the different stainers, slot number 15, again to reduce variation. And when we depicted the results, what you can see on the bottom right, there was quite a minimal difference for the 0 and the 3+ scores between the different stainers, but you can see that the red, the 2+ bars, show quite some variation, which goes from like 25 perhaps up to like 75, and that was way too much. And 2 of the stainers, they were even spiking towards the 3+ range. So we decided to dig a little bit deeper and did some experiments to see if there is variation between the different slots in an individual stainer. So we took one stable and one unstable stainer and positioned the slides in different positions within the stainer, in both stainers the same, position 1, 5, 10, 15, 20, 25, and 30. The stainer that was previously unstable showed more variation between the slots for the 1+ and the 2+ scores, and the stable stainer showed stable results for all the different cores, as you can see depicted here. So here the red bar, for instance, is much more stable in this intra-run variation, and here it's way too variable for especially the 2+. Then we tried if there would be a difference if we would position the tissue ray core on different positions on the glass slide. So near to the label, in the middle of the slide, and at the end of the slide. We again took one stable and one unstable stainer, and the previously stable stainer showed now quite some differences for the 2+ score, up to 30%, and the unstable stainer showed less variation for the 2+ core. So that was a bit surprising. And the unstable stainer showed much higher 2+ core intensity that was actually close to the 3+ region. We also visualized these results just to make it a little bit more, apprehensible for the pathologist. Strong day, normal day, weak day for HER2. And you can see that this is a run control, that there is some variation. This is the 3+ cell line, which is fairly stable, even on a weak day. But you can see that for the 2+ cell line, there is big differences. On a strong day, it's really nicely in between 1+ and 2+, but on the weak day, it's way less than the 3+ cell line, and there's hardly any difference with the 1+ and the 0 cell line. We concluded that we had a problem, right? And we talked with the vendor, and this prompted a full scan of the different stainers and extra maintenance. And funny enough, there were some problems detected that we could solve, like fixing a clogged vortex mixer, aligning the piston that pushes the antibody and the DAP on the tissue slides, and reducing the amount of fluids that we push over the slides to wash them. And after maintenance, you see that the results were much more stable. Just look at the red bars again for the 2+, and you see that after maintenance, the results were much better than before. So that actually shows that you can detect some hidden problems within these machines by having this technology in place. Just to make sure that these results were not unique just for HER2, we decided to repeat some of the experiments for PD-L1. Essentially, we got the same results. On the left, you see the variation over time. You see that for the 3+, there is some variation. For the 2+, there is some variation. And even for those 0 and the 1+, you see these lines here. There's little variation, but probably this variation where, the 2+ and the 3+ are within the same range, almost from this moment onwards. And that's unacceptable. This is the experiment repeated for PD-L1 with the different slide positions. And again, for especially the 2+ score, you see there is way too much variation between the different positions within the same stainer. So that makes sure that it's not just HER2. This also applies to PD-L1 and probably many other antibodies that you might use in your clinical practice. Again, to visualize this, you see here strong day, normal day, and weak day. And again, especially for the 2+ cell line, you see that there's way too much variation between a normal day and a weak day. So we have this in place, and we do this routinely now. This is part of a big roadmap of AI implementation that we are very diligently working on in the UMC Utrecht. And you see that we have different AI applications in place, the Ki67 from Sectra, a mitosis counting algorithm that we made ourselves together with the Technical University in Eindhoven, TIL counting that we're working on ourselves, and lymphovascular invasion that we're working on ourselves. And we have the whole suite from Visiopharm in place, the Qualitopix, the ERP HER2 Ki67 biomarker applications. We routinely do lymph node metastases finding, and PD-L1 has recently been added to this arsenal. Also for skin, we have an application for prostate cancer and lymph node metastases finding. We work with PAGE, where we have some nice results. And also with the DeepMed company, we work on implementing a lymph node metastases finder. So it's quite an extensive program that bit by bit we implement in clinical practice, and Qualitopix is now part of that for almost 2 years. So to come to a conclusion, I think I've shown that the Qualitopix AI algorithm enables monitoring stain quality by measuring expression of engineered control cells. In our hands, this detected some worrisome variation over time between stainers, between slots within the same stainer, and also with regard to slide positions of the control cells. These were problems that we had not detected before. So I think this shows that AI can detect this malperformance better than the human eye. And in our hands, this prompted replacing antibodies and extra maintenance that truly helped to solve the problem. So I think this is an important development and an important area of application of AI in daily pathology practice. So where do we go from here? One important question, of course, is how clinically relevant are all these variations? Honestly, we're not really sure. Clearly, some of these variations may not be clinically relevant because they don't classify a patient into a different category. But I think that I've shown at least some examples where the different classes spike into each other region, and this may lead to a false result for an individual patient. So I think we should try to avoid this type of variation. What we would like to do is similar experiments for other type stainers, because by far, I think this is unique for the Ventana stainers. I'm not aware of any other published experiments on other type stainers, but I know they are ongoing in different places of the world. And I've heard, not seen, I've heard that variation detected was the same. So I think it's going to be, in a while, quite clear that this just doesn't hold only for the Ventana stainers, but probably for all the different other stainers that are on the market. I think we're going to need control engineered cells for all the therapeutic protein targets that we have. There are different ones around now, but not for the full arsenal that I showed you in the beginning. So I hope that the companies will work on that to provide also for the other therapeutic targets, these type of engineered cells. And what we're really thinking of is not to do this experiment just once a day with one slide of control cells, but to actually mount these engineered control cells on all the slides from individual patients where we do a staining. Now, the cost of that are about €5 per slide. We do about 60,000 immunostains, not all therapeutic targets, right? So, but suppose that we have, in the end, control material for all the antibodies that we use. I think for now, we will be limiting ourselves to the therapeutic targets. So then this is a clear overestimation. But in the end, we could end up with having control cells and the cost for all these different stainings, which would be in my lab about €300,000. And somebody needs to start paying for that, because I think it's probably worth it to do it, to make sure that we have optimal immunohistochemical stains for all the different antibodies that we use. So let's see what happens. So thanks to especially Sven van Kempen, he was the technician who did all the experiments. So I'm really grateful about the hard work that he put in. And of course, we are grateful to the companies that have collaborated, not officially sponsored this study, because this was our study. But of course, we used the Hamamatsu machines, we used Visiopharm algorithm, and Roche provided us with some of the extra kits that we needed to perform some of these experiments. So they are also thanked for helping out to make us complete this study. So this is what I had in mind to tell you today. I think it shows that this is a very nice area of application of AI, and this could really help us to improve our daily business of performing immunohistochemical stains in our pathology labs. Thank you very much for your attention.
Okay, thank you very much, Paul, for this talk. Could you switch on your camera? Hi. You're on mute?
With sound.
Yeah, thanks. Okay, so I would welcome everybody to put questions into the chat. so that we can discuss with Paul. So that was a very extensive experiments that you performed in your lab.
Yeah, it was quite some work, but again, Sven van Kempen did all the hard work that I'm presenting here today. But yes, altogether, he's been busy with this for quite some time. But I think it yielded some nice results that have learned us a lot about the potential application of AI in monitoring this type of staining quality. So it's been very fruitful, and I think we've learned a lot.
Yeah, there comes the first question. What is the biggest source of IHC stain variability? Human error, reagent variability, stainer errors, or something else?
Oh, that's a hard question. I cannot just answer that, of course. That depends a lot on especially the type of antigen, right? For some of the well-known antigens that we've been staining for a while, for like decades now, we have very good antibodies that we didn't have in the beginning, right? So I think that the problems are much less at this very moment for antibodies like ER, PR, and HER2, just to name a few. So over the years they have improved. So I think they're probably the biggest variation is between labs. What I've seen for Key 67, just to give another example, is pretty dramatic. Once we did a study where we took a tissue array and we sent it to different labs. We had them stained locally, and then one observer counted the number of positive cells, and they could easily vary from on the same tissue core from 0 to 30%. So that's partly the lab, at least. For some things, the human eye is not very good, I think, or things are simply difficult. I always have problems with heterogeneity. I'm sure you have them too. Some parts stain well, other parts do not stain very well. So how do you come to an overall result? PD-L1 is not so easy to interpret. The CPS score is quite difficult because you're supposed to count non-tumor cells which are positive, which is a lot of work and not so easy. So it varies from antigen to antigen, but I think I've mentioned a number of sources where it can go wrong. Indeed, the human eye, sometimes the stainers that provide problems, sometimes the antibodies, sometimes the tissue processing in your own lab, and of course, human error.
Okay, yeah. Next question we have. With your experience, do you have advice for labs that want to improve their quality? Where to start and how, or what are the low-hanging fruits?
I mean, this is not so easy to just implement, and it's costing money, right? So I can well imagine that not all of you are jumping on implementing Qualitopix tomorrow. So probably is having a quality system in place in your own lab is step number one. I think that's quite normal these days. And participating in external quality control rounds like UK NAQUIS and the Nordic is probably the second logical step. This is maybe the third step for labs that are interested and see the importance of this application of AI. So yeah, probably this is how you move in monitoring the quality of your stains. What we have in the lab, that all the stains are being quality checked by the technicians before they are being scanned. We work digitally before they're being scanned and sent to the pathologists and residents. So, but I think that's quite usual over the different labs to do this kind of thing. So I doubt that that's a very special thing only in a few labs. So there's different ways that you can work on the quality. Using ready-to-use antibodies is often a good idea because then you don't have the dilution problems that you may have in all the different quality control runs that you need to do in your own lab to make sure that these antibodies are working well. To have antibodies with CE-IVD or FDA approval is a good idea because they're supposed to be quite stable and work very well across labs. So these are a number of things that you can think of to monitor and improve as much as you can the quality of your IHC in your lab.
Yeah, sounds good. Next question we have from Michael. Thank you for a wonderful presentation. Can you perhaps comment a bit more on the business case for adopting continuous quality control with the current levels of budgets for pathology labs?
Yeah, that's a very important and at the same time a very difficult question. People like Sven, the technician that did the job, he's now kind of pushing me to sort of stop with our own quality control for the antibodies for which these amyloid control engineered cells are available. And so I've now challenged him to make me a calculation how much more that's going to cost. I'm very much in favor of continuously improving the quality of our IHC, but that doesn't mean that we just have the money for that. So if we start implementing this more routinely, so not in batch mode, because the results that I've been telling you is like a batch thing we do on the days that we do this. We stay in one slide. When we switch to single slide mode and we mount these control cells on the slides of the patients where we do the actual staining, that's going to be €5 per slide, approximately. So if you calculate that the consumable cost for a single stain is about €5 as well, that means that the consumable costs per stain are almost being doubled if you start doing this in single slide mode. And that's a serious thing. That could cost easily for the different therapeutic targets, where of course this is most important, up to perhaps 10 or 20,000 euros a year. I'm not sure because I'm awaiting the calculations, but it could be that much. It's not going to be like we're going to get a lot of extra money to do this. I think the patients, the doctors that request sustains have a clear interest in having an optimal result, especially for the therapeutic targets on which these very expensive new therapies are being based. But are they going to give us the money for that? Well, yeah, not in my place. So somehow we have to try to realize this, and that's a bit of a problem. Yeah. So I think the business case is not easy, because when we do a better job, we make sure that the right patients get the best treatment and the right treatment. But that doesn't mean that money that we save elsewhere will just flow to us. It's not like that in most institutions. So the business case is a bit of a problem.
Okay. Next question from Sonia. Thanks for a great presentation. How much was the workflow affected by adding Qualitopix?
Well, Sven's not here to answer that question for me. Not much in this stage, because we did it in batch mode. Again, Sven is actually available. So maybe, Sven, can you turn on your camera and your mic and answer this question for me, please?
Wait a minute, I'm allowing him. Sven, you should be able to.
Yes, if it's okay, you can hear me?
Yes.
Yeah.
Yeah, so we have one technician from the diagnostic immunohistochemistry lab that's doing weekly uploads now. So it's just cutting a few slides from all the markers that we have in Qualitopix once a week at this point. After the study, we just continued with it. But we are working on the automatic pipeline, and as soon as that's working, we are gonna switch, hopefully, to the cell lines on every patient slide that we have, and then if there are automatic uploads, then the workflow doesn't change that much because you just see the results within an hour. Yeah, so you can really check the quality of your stainings in the same day. But the workflow didn't change that much.
I think essentially when we switch to single slide mode, the workload is not going to change that much either. I mean, we mount a tissue array control on every single slide that we stain for an individual patient, right? This is homemade controls that we make. So we produce these tissue arrays ourselves. We have to carefully select the right material for that. We have to do quality control checks of the tissue arrays and so forth. When we start mounting in single slide mode these engineered cells, we will basically do the same. It's a tissue array, right? In this stage. Although companies are working on beads with the same principle, with a standard amounts of protein glued to these beads, so then it might be a little bit different. But in this stage, the tissue array block with the engineered cells will have to be cut and mounted with the single slides from the patient. So essentially, in that situation, the workload is not affected that much.
Oh, that's good to hear. So the next question is from Sabrina. Thank you, Paul, for the nice presentation.
Oh,
have you?
Maybe I can add something.
Yeah.
When we are discussing the business case, right? If we start doing single slide mode with these engineered cells, we can skip our own controls. right? So it's not just that we add things that are going to cost money, but we will lose some work that's also costing money. So we will save at least a bit of work and consumables for all the quality control. I'm not sure how much in this stage, but at least in single slide mode, we do something less and not just something extra. So, I think it's probably worth it, but we have to do some calculations to see where we end up.
Yeah, that's a very good point. It's also good to have less work. Coming back to Sabrina, have you implemented in your laboratory cell line controls a replacement to tissue controls for antibodies like ER, PR, HER2, MMR? For example, cell line controls from histocyte.
We use our own homebrew tissue arrays that we use as controls. So that's it. No cell line material.
Okay, so that's only the ones that you use with Qualitopix then, I guess. Yeah, which is also the ones from histocyte actually. Okay, any more questions? Yeah, Mats has another question. What is the downstream effect of high stain variability? I know it's hard to answer, but do you get the impression that it affects patient care, or are the errors caught before it gets that far?
Well, it can, as probably you all do. The technicians, they check the stain quality of each individual slide, right? And they compare it with the control tissue array. So I think that most errors we catch. The variation that we see, to which extent is that clinically relevant? I've been a bit careful about this, right? Because I'm not convinced that it has a lot of clinical implications. Even though we saw some variations for HER2, which I showed, you hardly ever see it spiking into another region. That's an exception. So I think it sometimes may happen. We're not sure in this stage how many variation we will detect if we are going to switch to single slide mode with these control cells. But I think the AI will help us to catch that variation really quickly, because that's when pointed out, we will get the results back in like an hour. And, maybe, and I'm not sure that Sven's gonna like me saying this, but maybe if we implement this, we can skip the quality control check, the visual quality control check by the technicians. And that's a lot of work. So then we save technician time. So maybe there's a bit of return on investment. So I think we should still do this. And we have to do further studies to really assess the clinical implications of the variations we find. I think you've seen the pictures. Sometimes even the visual difference in staining is quite high. And these are problems that we would probably detect by the human eye as well. So clearly further studies are necessary. I think the companies like what we found, at least Roche, they have been very open to discussing and interpreting these results with us, and very open to doing extra maintenance. So I think also the Roche company sees this development as an opportunity to monitor the performance of their staining machines and to prompt extra maintenance if the problem is being detected, as we did in this study. So I think that's good. And I would like the other companies that produce these type of stainers to start doing these studies as well for their stainers, because I'm quite convinced all the stainers will have similar problems.
Then I would say thank you to Paul and have a nice evening. Bye.
Thanks for being here. Bye-bye.